tell us who you are and what you're about.
Yeah, sure. So I'm predominantly an implant dentist based in North Yorkshire. I place implants at a number of practices. I own my own clinic in Harrogate, and I also run a full-service dental lab. I originally trained as a dental technician in Canada, and I did my dentistry and my master's in implants over here in the UK. Yeah. I place about 450 implants a year, traveling around and in my own clinic.
Yeah. And how many dentists do you think you've trained now in digital planning and surgery?
Good question. So I would say probably trained about 100 dentists on guided surgery in about probably over the last 2.5 years or so.
Amazing. Yeah. One thing I've heard from kind of people with a lot more experience than me is they've said that once they've moved on to kind of guided surgery, they realize all their primary holes were all in the wrong place. They're like, that can't be right, and that's something that they've learned.
Yeah, my first case where I realized it was, I was doing an upper 2 to 2, and I was placing in the laterals. And I guarantee you would never place the implants as close to the canines as you would freehand, as you would with a guide.
Yeah. It's scary.
Because they've got to be right there so they emerge out properly.
Right.
And I have so many cases where they're just a little bit too mesial, and you have those stupid looking crowns that are like half a central, half a lateral.
Yeah.
Because there's too far mesial, right? Yeah. And I hate that. I hate it. So that for me, it was the sticking point in saying, you know what, my placements were fine. Of course, I can place an analog implant, but they're not as tight as I want them to be.
Wicked. So let's debunk some of this. I mean, so you know, as I was saying, I always think there's a stumbling block in I come away and I think, okay, I understood all those bits, but I still don't feel like I could just go away and do it. And one of the things you've just said is, you know, you think that it's because we don't have a clue what the lab side of things are. So there's always going to be that block.
The implant surgical guide process, again, it's all about developing a system where you can assess a patient and look at them and say, what data do I need so I can make a surgical guide for this patient?
Okay.
And generally, that data is a cone beam scan and an STL surface. Now, an STL surface is just a digital, basically a digitalization of an impression or an intraoral scan.
Yes.
Yep.
So those are the two things you need if you're going to do the surgical kind of planning and surgical guide. You just need a CT scan and then an impression of the mouth or a scan of the mouth.
That's right.
Yeah.
Now, when I look at them, I'm assessing the patient to determine, can I stitch the STL surface to the DICOM? And things that will hinder me in doing that is if there's a lot of scatter. So a patient that has a mouthful of metal, because the scatter doesn't allow specific stitching points for the two to overlap.
That makes sense, yeah.
Or the patient doesn't have enough teeth for me to stitch.
Right. Okay.
Yeah, because I need a number of stitching points around the mouth to be able to stitch them together.
And so if we stick with the easier scenario of there's enough teeth to the two STL files, and you've taken those two bits of information, you've sent it off to your lab technician, and he or she have stitched those two together. They will then plan the prosthesis digitally, will they?
Correct. Yeah. So then the workflow from there goes down the line of find out where the tooth wants to be, figure out the future incisal edge, and then work backwards for where the implant position is going to be. Okay. If there's not enough bone, remake the bone or consider angulated screw accesses.
Right. And this is the bit where a dentist does need to have a look at that and just make sure with the implant position, it's where they are comfortable with that implant being, you know, away from landmarks and all the other things that we need to consider. If I was wanting to, you know, sit there on a computer and take an STL file and take the DICOM file and stitch them myself, how long does that take from the beginning, and how quickly does it get if you get good at it?
Yeah. So now the softwares are so efficient, especially Blue Sky Bio, that it is literally almost drag and drop.
Okay.
So my course is 2 days. The first day is just doing the very basic, navigating the software, figuring out how to bring the DICOM data and the STL surface in, placing implant, drawing where the surgical guide wants to be, all that stuff. The
Yeah.
very basic stuff like you just described, just bring in the STL and we do that in the first hour.
Okay.
So, you know, I would say getting good at, getting efficient at it. So being able to make a surgical guide that's say less than half an hour,
Yeah.
would probably take a dentist no more than probably 3 or 4 months to be able to do that if they're doing it regularly.
Yeah. And I mean, to be honest, sometimes I think you know, on a busy week, I'd struggle to kind of find half an hour to do it without it being a nuisance. So
Yeah.
I understand where a lot of people kind of hand over the design of that, but yeah.
But when I say do it in half an hour, you starting out will probably take you more like an hour.
Yeah. So you've taken your STL file and merged it with your DICOM. You've then kind of had your lab technician create the prosthetic design, and then you, along with your lab technician, have just kind of okayed where the final implant position is, put some windows in, and then created that surgical guide ready to go. I know that there's some people who only use kind of a guide for their primary osteotomy, and then some,
like a pilot.
but yeah, and some people who choose to go fully guided.
Yeah.
For people who don't know, could you just explain what those two terms are?
Yeah. So a pilot guide is generally creating the initial osteotomy, usually to depth and in the correct angulation, using either a 2mm twist drill or a 2.2mm twist drill. Mm-hmm. Then the guide is removed, and the rest of the osteotomy is then produced with your normal drilling sequence.
Okay.
Now, with a fully guided system, essentially, there can be certain levels of fully guidedness, if you will. You can create the whole osteotomy with your guided kit, but then you can freehand the implants.
Okay.
Yeah, or you can fully guide the osteotomy and then place the implant through the actual guide as well.
Yeah, which makes the most sense to me. If you're going to go through all this effort, you know, I mean, how many times do you kind of prep an osteotomy and then find your implants being pushed a certain way?
Yeah, that still can happen.
Yeah, right, okay.
Even with the guide.
Yeah.
So if you can imagine you're placing a 13mm implant and you have a 10mm offset, all of a sudden you're picking up a 13mm drill.
Yeah.
Or sorry, a 23mm drill.
Yeah.
That's quite long.
Yeah.
So you have, if you can imagine, this kind of wag factor that can happen inside the sleeve.
Right.
Yeah.
Yeah.
So that wag factor can allow that deviation of the burr head to go kind of where you don't want it to go, if you will.
Yeah.
So the most accurate guides are the ones where the burr exits the surgical guide and almost instantaneously touches the bone.
Okay.
Yeah.
Yeah.
Now that you can, so there's a number of ways to go around this. So you could make the first guide a pilot guide where it has a very close offset to the bone, drill that first initial site. Once that first initial site's in the right spot, generally the next sequence of burrs is very easy. You're just expanding.
That's right, yeah, lower margin for error there, yeah.
Yeah. So then the next sequence, you then bring your fully guided guide over and then drill the rest with it fully guided with the offsets at the right position. So again, there's a whole bunch of different ways of going about it. I tend not to do that pilot hole first. I use just the regular fully guided kit, the pilot hole associated with the fully guided kit, which has a bigger offset.
Yeah, sounds like you need to get a fantastic mouth opening for doing some of these cases.
Absolutely. There's another thing that you have to assess. If you're going to be, if you're going to be placing a 10mm implant, or say, let's say an 8.5mm implant in an upper 6, you've got to make sure you can get that burr that's going to be 18mm in length into that site.
Yeah. Okay. And one of the things that I've heard a lot of is, everybody who's taken the kind of step that I haven't taken yet into guided has said, there is a steep learning curve, or there is a learning curve to it. What do they mean by that?
I think it comes down to the fact that when you have your guide in place, you can't see very much.
Right.
So you have to have some faith.
Okay.
And I think it's the faith that's the steep learning curve.
Okay. Yeah.
Because you got that plastic in place, it's pretty much obliterating your surgical site. Mm-hmm. And you drill that site, and you take it. In every case I do is my first site I drill, I take the guide off and I have a look.
Yeah.
If I don't like where it is, that guide's in the bin. I go back to analog.
Right. Interesting.
Because there's inherent errors that can be incorporated into the production,
Yes.
the data capture,
Yeah.
everything,
Yeah.
So it is supposed to be, I guess you could say, brain assisted surgery
Yes.
with a guy. You're still using this thing, right?
Yeah. So, I mean, well, I think the next logical question for me to ask you is how many of these guides do you end up throwing away because you're not happy with where the first guide pin comes out? How many,
Very rare now.
Okay.
Like, in fact, I can't remember the last time I didn't use a guide for a case.
Okay.
Yeah.
Why do you say very rare now? What's the difference now between...
Probably my learning curve.
Sorry.
Probably my learning curve. My data capture probably wasn't good. I didn't know in my design process where the faults would be.
Yes.
So undercut teeth, mobile teeth,
Right.
the stitching, all that all those errors that can be incorporated.
Yeah.
Now I know where those are going to come in my planning. So I kind of understand that where my guide's going to go wrong.
Okay. So if you're a dentist like me and you're trying to just maybe take your first baby steps into doing it, what kind of cost would it? I know there's obviously a click fee for Blue Sky Bio, which is averages, I think you were saying it's £18 or something like that.
Yeah.
Is that something, if I don't want to buy a whole kind of package, is that something that could be done through my lab technician?
If you were going to send the whole case,
yes.
So I'm going to plan it. I'm going to then fabricate the guide. You can get a 1 to 3 implant surgical guide. I think it's for about £180.
Okay. Well, let's say it was an upper premolar, and I've got teeth on either side, so I know kind of where I'm looking to place my implant. But what's the benefit of having a guide? If it costs an extra £200, I mean that's a cost that's going towards the patient. So I guess for me, it's not a massive barrier, but it's something I want to consider for my patients.
Yeah, for me, it's there's two things. I think in the future for implant dentistry in the UK, there is going to be an element on every single case has to have a forethought of where the prosthetic envelope is.
Yeah.
And then also considering, if that's the case, and also then considering, well, how would you apply that to your surgery? Okay. So that's where the surgical guide, first of all, comes in. Yeah. Mm-hmm. The second thing is I like to talk to my patients about how I'm going to do this. Okay. And they like the idea that I'm going to use this software to plan their surgery in a very precise and neat way. Yeah. So the £200 surgical guide fee for them is like a no-brainer. Yeah. And then it brings an element to them. They say, well, you're sitting there, you're doing this beautiful cutting-edge dentistry for me. Let's say something goes wrong. Of course, implant dentistry can go wrong. I find that they're more kind in saying, you've done everything you can. Because you brought out all the bells and whistles, if you will. Yeah. Yeah. So, that's another element. And also the other side of things is, I'm in Harrogate. There's probably 25 implant dentists in Harrogate. Mm-hmm. How do you set yourself apart? Yeah. 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 You do what you can do to be the best. Try to do everything as best you can. Yeah. And I think bringing surgical precision into surgical guides is one way. Yeah.
And I think, another thing with starting with a simple case is it's a great for learning as well. You don't want to wait until you've got that really complex case where you've got limited space and you're trying to squeeze an implant or several implants.
Absolutely. I think surgical guides, my favorite scenario for surgical guides is the free end saddle. An upper 4, 5, 6. Yeah. Where you want those implants to be bang in the middle of that future central fossa. Yeah. Not like kind of in between, not, I want them exactly sitting over top of where those teeth are going to emerge. And I don't care who you are, you cannot do that freehand.
Yeah. I mean, one time...
Sorry? You can get them close, but it won't be just there, right? Yeah.
Amazing. I mean, I think it'd be, it's having someone like you, you're a rare commodity. So someone who fully understands every aspect of it. Well, thank you very much.